Yeah, Dr.
Yeah. Hi.
Hi. Yeah. Myself, Dilip Chaudhary. Nice. I got little bit 2-3 minutes late. Actually. So nice of you for joining on time. So I just say as a protocol, because I'm the president, I'm just saying that let's start with the seminar, and I will hand over to the project coordinator, Mr. Naveen, for the further proceeding. Naveen, please proceed, and let's start with this.
Yeah, thank you, President. I formally welcome you all on behalf of Rotary Club of Calcutta Yuvis and Calcutta Avyana. The purpose is well known to everybody, as forwarded by with the help of speakers and all. So now I'm going to introduce the guest speaker, Dr. Neha Chaudhary. So please go ahead with this. Thing. She will be going to speak on the breast cancer awareness, particularly in this COVID time. Dr. Neha Chaudhary is a certified breast surgeon trained at Tata Memorial Hospital, Mumbai, and working exclusively in the field of breast surgery. Specialist in the surgical management of cancerous as well as non-cancerous condition of the breast with treatment based on the current evidence. She manages breast cancer with oncoplastic approach maintaining safety. She has many national level presentation to her credit and is a member of many national and international cancer societies. She also has keen interest in breast cancer research and has been actively involved in many clinical trials for the same. At present, Dr. Neha is attached to Narayana Super Speciality Hospital as consultant breast surgeon. So I hereby present Dr. Neha Chaudhary Agarwala, MBBS Gold Medalist, MS General Surgery, SBNI Breast Oncology Fellowship, TMH Mumbai. So welcome, Dr. Neha. The floor is yours. Please go ahead.
Thank you, Mr. Naveen, for a very beautiful introduction. And I think we will try to keep this as interactive as possible. At any point of time, if anyone wants to ask any question, please stop me and we will try to discuss it. If anyone has any personal experiences, it will be great if you can share it. I will start a little bit. I'll just be sharing my screen. Someone has to allow me to do the screen sharing.
Yeah, I'll make you host.
Naveen, can you also please mute everybody other than the guest speaker?
Yeah, please.
Mute everyone other than the guest speaker. Thank
you. Yeah, so I still can't share my screen.
One second.
It's saying host disabled.
Yeah, Dilip, you have to make a Dilip President. You have to make her host or co-host.
I'm not able to co-host. Now you can operate as your wish.
Yeah, you now co-host, doctor.
Yes. Now I think it's. Yeah, is my screen visible?
Yeah.
Oh, okay. Just a minute.
Yes.
So we'll be talking about breast cancer awareness, and I would rather call it be breast aware. So it is awareness about breast cancer as well as the normal breast. So a little bit about what do breasts mean to a woman? I mean, why is it so important? So it can mean different things. It can mean for someone it is just what they are, the identity of being a woman, the sense of their femininity, their intimacy, their role as a mother or as a sexual partner. It can mean various things to various people. And when we hear the term breast cancer, what does it mean? There are a lot of people who have a lot of vague concepts about cancer. People think it's some kind of an infection, some kind of a germ. But what exactly is cancer? So cancer is basically when these cells, our whole body is made up of cells. And the cells, they have this tendency to divide from 1 to 2, 2 to 4. And it is because they are dividing, that is why all the repair mechanisms in our body is going on. You know, the lining of our mouth, of our intestine, every repair mechanism is happening because these cells divide and they repair it. But this repair is going on under a lot of controlled way. And when the body loses this control, when this division becomes uncontrolled, that is when we call it cancer. So You know, it has both. It has some genetic aspects and some environmental aspects. A little bit about the anatomy of the breast. What exactly is breast? Breast is a modified dermal appendage. That means it is a part of, it is basically arising from skin, and it lies on our chest on this muscle. This muscle is known as pectoralis major. And this breast is made of lot of ducts and lobules. So these ducts and lobules, they extend from a thin membrane on the pectoralis muscle till the nipple areola complex, and that these lobules and is where milk is formed, and the ducts are like pipeline which bring it to the nipple. Important thing to understand is the whole breast is drained by lymphatics. So lymphatics are basically channels which drain excessive fluid from the breast to back to our heart. And in this process, these are the lymphatics which also carry the cancer cells to other part of the body. And that is why these lymph glands in our axilla are so important in breast cancer, because this is the first place where cancer cells will go. And from here, it will go to the rest of the body. So you see here from breast, it can go to the axillary nodes. Then there are a group of nodes just above our collarbone, which is known as supraclavicular. And there are a group of nodes inside the chest wall, which is known as internal mammary. These are the three important nodes in the body. And breast cancer has a tendency to spread to these places: brain, lungs, liver, and bones. If we look at the burden of breast cancer in our country, we see that breast cancer is most common cancer, not just in women, but if we take both the genders also, then also it is the most common cancer, 14%. And in women, it is almost 27.7%, which is pretty high. It's the highest, incidence of the cancer. If we look at the ranking, it is the highest in the number of cases, as well as highest cancer causing death. If we look locally, just in Bengal, then it is again the most common cancer in women. 50% of breast cancer patients in Bengal is less than 50 years of age. So what we need to note here is that in India, and specifically in Bengal, a lot of younger women come. I see so many 30, 32, 33-year-old women who have breast cancer in OPD. And out of every 2 women who get breast cancer, 1 dies of it. So that is 50% mortality, which is very high. If you see Western countries, then they have somewhere around 10% mortality. And why is this happening? This is happening because 72% of our patients come in late stage. They come in stage 3 or 4. So if we think about what causes breast cancer, a lot of people say, "Mujhe kyun hua? Why me?" So we don't really know exactly one reason why there's breast cancer happening. It is a combination of multiple risk factors. We do know that there's some kind of genetic mutation going on, but what is exactly triggering it? There are a lot of risk factors. So what can be your risk? What can be someone's risk? First is female. So women are likely to get breast cancer 100 times more than men. Men also do get breast cancer, but it is much, much less. Having a family history of breast cancer, if you need to know if your family, someone has had breast cancer or not. Being overweight or obese, especially post-menopausal obesity, is something which increases your risk of breast cancer. Alcohol increases risk of breast cancer. Breastfeeding is protective. So more you breastfeed, more you're protected from breast cancer. And getting older, because breast cancer, as you increase, your age increases, the chances of having breast cancer is more. And a few more risks could be genetic factors. A lot of you would have heard about BRCA1, BRCA2 mutation. You know, so how Angelina Jolie had BRCA mutation and she got both her breasts removed. That is because she had one of the genetic syndromes where her risk of having a breast cancer was very high, more than 60 to 70%. So you need to know whether your family has one of those syndromes. Personal history of breast cancer. Someone who's had breast cancer on one side can always have it on other side. The chances are more. Previous history of chest radiation or hormone replacement therapy also increases the risk. So what can you do? What can you do to protect yourself? First thing is know your risk. Ask your parents, ask your relatives, how many people in the family have had breast cancer or ovarian cancer. Talk to your doctor about your risk of breast cancer. Second is check yourself. Know what is normal. So what we say is that only if you know what is normal, you will ever be able to know what is abnormal. So to all the women, do self-breast examination. Stand in front of the mirror once a month, just after your periods preferably. Look at yourself. Look how your breasts are looking. Are the nipple in the right position? Are there any lumps? Is there any scar? Venous dilatation? Lie down and with the this palmar aspect of your hand, check yourself, check the entire breast for any lump. And if you see any changes, report it to a doctor. Get screened. So screening means that you are absolutely normal. You have no sign, no symptom, but you're still actively going and getting yourself checked for any hidden signs of cancer. And screening is what is actually bringing down the incidence and the mortality rate of breast cancer so low in Western countries, because they have national screening programs. So how can you get screened? You can go to a doctor, get yourself physically examined, get mammography once a year. So screening is usually advised for women who are more than 45 years of age. What else can you do? Make healthy life choices. So that also can reduce your risk of breast cancer. What are the healthy life choices? As I said, breastfeeding. Early pregnancy, I mean, it's a very debatable topic. Avoid long-term use of any kind of hormone replacement therapy, estrogens, menopause medicines. Avoid weight gain. Decrease saturated fat. More fruits. More than 3 hours of physical activity every week. Limit alcohol. So now we see that the mind, the eyes do not see what the mind does not know. So you need to know what are the signs and symptoms of breast cancer to be actually able to know that you have something. So for everyone, I think we keep repeating that these are the signs of breast cancer. Please know it. So most common sign would be a lump in the breast. And one thing which a lot of people feel that if there is no pain or discomfort, then probably it is nothing. But most cancers, the lump is painless. So just because there's no discomfort doesn't mean it's not important. A discharge from the nipple, usually blood-stained discharge, is very, very indicative of underlying cancer. Dimpling in the skin of the breast. Here you see some kind of a dip in the skin of the breast. Pain or nipple of breast or nipple can be a sign if the nipple is pulled in or retracted, if there's a redness or swelling of a specific area of the breast, changes in the skin texture, if there's any ulceration, thickening, if you can feel lymph nodes in your armpit, so lymph node changes, and swelling of the entire breast. So what will happen if you suppose detect something which is suspicious? You go to a doctor. The next thing they will do is they will do a clinical examination. And after checking you, if they feel that, yeah, there is something which needs to be done, then the next step is imaging. Imaging means some kind of a X-ray or an ultrasound. So mammography is basically X-ray of the breast where the breasts are seen like this. This is a mammography of the breast. Ultrasound, I think most of you know what is ultrasound. Or MRI breast. MRI is usually done in very selective cases, not as a usual diagnostic modality. And after we do one of this imaging, if you think that there's something suspicious on this imaging, then the next step is to do a tissue diagnosis. That is, some cells or a part of the tissue from that suspicious area is taken and seen under a microscope. So that can be done through FNAC, true-cut biopsy, or excision. You can remove the entire lump and see. The most common and the best way is a true-cut biopsy, because it is a non-invasive method. It is a 10-minute OPD procedure. You come and you can walk out, go home after 10 minutes, and we can get all the information that we want. After we have the diagnosis, the next thing we usually do is we do some kind of a staging workup to see whether the cancer is limited to the breast or it has gone to the other parts of the body, like maybe liver, lung. For that, usually we do a CT scan or a bone scan or a PET scan these days. We do more commonly PET scan. And after we have all this information, the biopsy, mammography, the scans, then we classify the breast cancer into various stages. So stage 1 and 2 is early breast cancer. That means the cancer is limited to the breast or the nodes in the armpit. Locally advanced breast cancer is usually when the cancer has grown enough, more than 5 centimeters, it has involved the skin of the breast or the muscle under the breast, but it is still limited to that area. And metastatic breast cancer, that is stage 4, is when it has gone to some other part of the body, maybe like lung, liver, or bones. So next, once the staging is done, then the treatment is offered. So breast cancer has got 3 main modalities of treatment: surgery, systemic therapy, and radiation therapy. Surgery can be breast conservation therapy or mastectomy. Wherever possible, wherever we can offer breast conservation therapy, we offer breast conservation therapy to the patient. But for some reason, if the lady has to get mastectomy, we also offer whole breast reconstruction, that is plastic surgery techniques to make the breast again. Systemic therapy is something which which is usually given orally or via injections like IV saline and all. These are chemotherapy, endocrine therapy, and targeted therapy. This targets basically the cancer cells which are spread to the other part of the body. And radiation therapies are rays which is given locally to the breast and to the local regional lymph nodes to decrease the recurrence. Overall, if roughly it takes somewhere around 7 to 8 months to complete the entire treatment for including all these three. So this is a very important slide. I would like everyone to have a look at it. That if breast cancer is detected early, that is in stage 0, that is in the pre-cancer stage 1 or stage 2, then the 5-year survival rate, or almost we can say the cure rate, is very high. It's more than 80%. So I think I'll just pause here. And if anyone wants to ask me anything or discuss anything. I'll stop sharing.
Shall we take the questions later, or?
Yeah, you can have it.
We can have some discussion here, because the next part is a little bit of what we are actually practically doing at Narayana Hospital. So if someone wants to discuss something about breast cancer,
Okay.
or has any queries about COVID and cancer.
I would like to ask you a question, doctor. Am I audible?
Yeah.
Yes.
Yeah, please go ahead.
I'm listening to you very eagerly. It's also kind of a bit traumatic for me, because my co-Rotarians at Avyana know currently my twin sister is undergoing this therapy. Okay. So while, like I said, so it's important. I'm curious, eager, and at the same time actually having palpitations. But that apart, I have a query. What are the possibility of a twin getting the same cancer? Okay. There is a bit of a family history. My aunt, Mausi, did have it, and therefore my twin. And also, while many of my doctor friends and other friends have asked me to go for checkup, which I have done, mammography, they have asked me to do it later because of the COVID situation. And so far, so good. And my blood group is also other than hers. Does that have an implication? Because we are twins, not even sisters, twins. So therefore,
first thing is, I would like to know your age. I shouldn't ask it in a public.
No. We have crossed those, vanity issues in this generation. I'm 61.
Yeah.
I'm 61.
And is your twin an identical twin, or because you have different blood groups? So
probably we thought all along that we are identical because we look the same, we sound the same often, but well, surprisingly, the blood group is different.
Yeah, then probably in that case, you're not identical twins. And see, at 62, if someone is having breast cancer, then the chance of that being genetic is much lesser. Okay. And if you're not sharing the same set of genes, then that genetic factor also decreases significantly. So I think your risk would be same as any other person. But yes, as you mentioned, a lot of people in your family are having breast cancer or ovarian cancer. So that is something you need to have a look at, and maybe meet a genetic counselor. What they do is they draw up a pedigree chart and they calculate your risk of having a breast cancer based on certain set formulas, and they tell you what exactly your risk is. And okay. Then actually how it won't really matter, because eventually the action is going to be same. You should ideally at your age have once a year checkup, mammography, and that is what you'll be anyways doing.
We also hear that it is not very advisable for mammography. You think once a year, continuing from this year, is okay for?
Yes, see the dose of radiation in mammography is very less, and once a year mammography is what people usually say. and got
Okay.
various the American Cancer radiations, of American Society of Radiology, and all these various societies. They have various different sets. Some people would say once in 2 years. Some say once a year. Some say you start at the age of 45. Some say you start at the age of 50. So what I feel that you start at the age of 45, start getting once a year mammography, and then maybe once you've got mammography once or twice, you can increase the timing, maybe make it once in 1.5 year, and then keep following it like that. But
Okay.
practically,
Okay.
the dose of radiation is not going to harm you.
All right. Thank you. Thank you, doctor.
Hi, I just wanted to find out, because you just mentioned that below 50 years, you're finding a lot of patients coming in. So what's the reason for that? And especially in West Bengal, is it due to the pollution or the water, or what is the reason that you're finding it so much over here?
One thing is that the population pyramid in India, if you look at the set of population which is there in India or in Bengal, we have more younger people compared to Western. So our whole population is like that only, that there are the number of people who are younger are more. So that is obvious that the number of people getting breast cancer will be more at that particular group. Another thing is, even if we discredit that population pyramid, then also I feel that we are having more younger patients. And I think that is probably something to do with our ethnicity and the race that we have. And that is the reason. It's difficult to say exactly why.
Is a lifestyle also, you feel?
Definitely, I think lifestyle also.
The diet you're consuming and the type of life you're leading. High stress. Stress does lead to cancer, that's what I hear.
I think stress, it's a very unresearched area.
I heard, yeah, exactly.
But there are a couple of trials going on in Tata Mumbai where they have actually randomized patients into yoga and not doing yoga, and they found that people who are doing yoga, they have lesser cancer. So of course
That's exactly what was my point, because stress does, I felt also. Thanks, Neha. Thanks.
Yeah, we have Chainika. Chainika, beta, you can ask question. We have a kid from the Rotary family, Rotary Yuvis. Beta, ask your question.
Hi, I'm Chanika.
Hi, Chanika.
I actually had a question regarding a cyst-prone body. So my body is prone to having cysts, and I was said that I have fibroadenoma, those glands in my breast, those lumps in my breast. But this was like 3 years ago. And then afterwards, when I recently got another sonography done, it turns out that those were not actually fibroadenoma lumps. They were just cysts which had ruptured. And then they were like, looking like tissue masses, which they weren't. So that was the whole situation. So basically, it was just a cyst. And I am not able to understand how to approach the thing and maybe how to reduce the whole cyst-prone issue of mine.
So, Chainika, first of all, on an ultrasound, it is very, very easy to differentiate a cyst and a fibroadenoma because they look very different. So it's very surprising if someone has called a fibroadenoma cyst or a cyst of fibroadenoma, because they look pretty different. Second thing is, you look pretty young. I don't know what's your age, but I don't think that breast cysts are very common at your age. What is more common is fibroadenomas. And sometimes fibroadenomas do have a tendency to regress on their own. They go away on their own. So I would say that don't worry so much about a tendency to form cysts, because if they're simple cysts, anyways, they're not going to cause you any problem. And if they're fibroadenomas and if they're not present right now, then anyways, you don't need to worry. What you really need to do is you need to be under follow-up once in 6 months. You need to go to a breast surgeon, get yourself checked, maybe get an ultrasound done to see what is your current baseline. And then depending on that, follow up how it goes. Okay.
Okay. So much.
Did that answer your question?
Yeah, actually, I was just thinking now that he was also saying one more, the doctor that I consulted, he also said that they were cysts which had ruptured. So they weren't actually solid cysts anymore. They had ruptured, and due to the rupturing, due to the hemorrhaging, that is why it was looking like a adenoma. It had formed like a tissue-like condition. So is that possible?
Okay, so maybe, see, I'll really have to look at the exact report. What is it saying? Maybe it's some kind of a calcification or something, but it's very difficult to specifically tell you what was it. But Yeah, cysts can always rupture. It's not something you should be worried about.
So it's like I'm healthy that way. I don't have to really concern with.
No, it doesn't look like that.
Okay, thank you.
That's a relief, right?
Can I ask a question?
Yes, yes.
Yeah. Hi, Neha. Yeah, I wanted to know about calcification. What is it, and is it something to worry about, or?
Yes, so calcification can be classified into like a whole lot of categories. There's an entire spectrum of calcification, going from benign calcification, intermediate, and very, very suspicious calcifications. In fact, on mammography, we can classify calcifications into various ways. So just a calcification is not something to worry about. Usually, if you get a mammography done, there'll be one or two benign scattered calcifications, and you don't need to worry about it. There are certain varieties of calcifications which are, a bit suspicious, like pleomorphic or clustered. If there's a lot of small pleomorphic calcification in a specific area, or a clustered calcification, then that needs further evaluation.
Okay.
But otherwise not.
Thank you.
Anyone else? So doctor can go ahead.
Yeah. So a couple of things about, because I was thinking I would also talk a little bit about COVID and breast cancer and how it has changed the scenario of, the entire medical treatment. Everything has changed in past 7-8 months, and a little bit of personal experience of what we have faced as oncologists and in Narayana. So, it started in March. So in March, there were a lot of people who were coming to us and suddenly they vanished. And they've just started coming back to us with, a 2-centimeter lump, which is now say 7 or 8 centimeter, and a lot of upstaging. And then we are having to deal with, giving them chemotherapy, or maybe if they've turned metastatic. So this is one thing which is very, very common in OPD currently. And I keep telling them that your risk of dying from COVID is much, much, much less than your risk of breast cancer. So please, with people with known diagnosed cancers, please do not delay or withhold your treatment at any cost. And people who have any kind of suspicion, if you think there's a lump or something, take due precaution, wear mask, do whatever possible, but come and get checked. Like, don't delay your the other treatments because of COVID. That is one thing which I've been telling and I've been requesting everyone. A couple of things which has also changed due to COVID is how the treatment, we are also giving treatment. Like before COVID, we were doing a lot of plastic surgeries, lot of reconstructions. But in past 6-7 months, the amount of reconstruction or cosmetic part of the breast cancer had really gone down. We were trying to do just the bare minimum, what is possible, But now again, we have started doing plastic surgeries and reconstruction. So that is back. Third thing which I realized is, since, due to COVID, we do not allow relatives when the patients are admitted in the IPD. So that does cause a little bit of stress to the patients. They do feel really scared that, no, I'll be alone, I won't be able to contact anyone. But, most hospitals, they try to make the patients as comfortable as possible. You can do video calls as frequently as you want. And the sisters, they try to be friendly and try to settle you down. So, that it is a little bit of hitch, but not so much as to delay the treatment. These are things. Fourth thing is chemotherapy in COVID. There's a lot of discussion that, chemotherapy is going to further decrease your immunity, and is it a good idea to give it during the COVID times? And in our experience, we really haven't seen increased mortality because of chemotherapy and COVID. We did have a lot of patients who were COVID and had chemotherapy, but most of them did well. So that is not something that we faced. I'll be sharing a little bit short, presentation of what we do at Narayana. Just a minute. So, unlike traditional breast cancer management, what at Narayana we do a multidisciplinary management of breast cancer. We have a whole surgical oncology, medical oncology, radiation oncology, oncopathology, radio diagnosis, plastic surgery, physiotherapy, genetic counselor, medical social worker, and psychologist. So this is an entire team which manages breast cancer. We try to do less wherever possible. So wherever we can avoid removing the entire breast, and conserve the breast, we do. Wherever we can avoid removing the entire axilla and doing a sentinel node biopsy, that is what we do. So best possible outcome with best possible cosmetic outcome with best oncological outcome. Since, as I said, we're getting a lot of younger patients, so issues regarding fertility preservation is again what we need to discuss, and we discuss regularly. Post cancer therapy treatment, post treatment rehabilitation, there's a lot of side effects like lymphedema and other, and we have an entire department for that. The lymphedema prevention, arm care, genetic testing. We do manage all the psychosocial issues, also discuss about rehabilitation, and then the regular follow-up, that is once in 6 months we follow up the patients. We are associated with social workers, NGO Hitayishni, and we have an extensive outreach screening program. Our CSR team goes to a lot of rural places to do screening and detect breast cancer wherever possible, and they are referred back to us. So this is what we are doing at your scale. Definitely not as much as a Rotary Club is doing, but whatever we can do at our scale, we're doing this.
So lovely, Doctor. We also did in Rotary Yuvis a year or two back. We had a lot of programs Pawan has done in the leadership of last 3 years back. So we are very much interested to have once the things are normalized, we are actually not having these virtual things in a better way. We should have done it actually at the field of the place. So if any more questions by
COVID
anybody, please.
COVID has taught us to do things on Zoom. It has brought about this entire new opening to us to do a lot of Zoom and virtual conferences, and this is something which we never actually really seriously looked at, and we should actually kind
I
of
think it reaches out to more
also.
people.
Yeah, we should cash on it.
It reaches out to more people, and like this webinar is so informative, so I guess this is how it is. Like everybody sitting in their house can listen to you. Otherwise, it's very difficult. So it has its pros and cons, I'm sure. Physical is different, and again, virtual has its pros also. It's very nice, yeah.
So
yeah, as Naveen ji said, we have time to have some more questions.
Yeah, if any members want to ask anything, they're most welcome to, I guess.
Dr. Neha, I have another question again. Are cancer patients more susceptible to getting COVID infected because of their low immunity, or are they as good or bad as others?
Yeah, so like I just said, that in theory, it says that, they are more susceptible to get COVID more. But in our experience, if we say about practical experience, we have not seen that. We have not seen an increase COVID-related complication in our cancer patients specifically. So I think it just needs more research and all, but in practice, we have not seen something like that.
Okay. That's a relief, because patients who are currently undergoing treatment, it's a tough call for their family to keep them safe, and to, we as normal healthy people, we have to take so much of precaution, and patients who are undergoing chemo, etc., it's hellish. It's hellish for the family and for the person.
The travel and everything. So
and when the family member, they sometimes have to go out, and to be that much cautious that they're not carrying the germ back. The everyday difficulties that one has.
Doctor, I have
a Shruti, yes, Shruti.
Yeah. So do you just specialize in breast cancers? Like, I have these nodules on my thyroid gland, and after the ultrasonography, it's showing between something beta 2 and 3. So is it serious?
Yeah, so I am not an expert
thyroid,
about thyroid
yeah.
cancer. We do have a team of various oncologists. Like we have because in Narayana we're practicing organ specific. So like I am doing breast, then there is a team of
Okay.
head and neck oncosurgeons. So
Okay.
maybe they
Yeah,
would
so
be
this
able
comes
to
under
answer you
head and
better.
neck.
But
Yeah.
yeah,
We have Manoj Pachari, our past president, and now the grant committee members in the district. Yeah, Manoj.
Hi,
please
Dr.
unmute.
Neha.
hello.
Hi, good evening. First of all, it might sound a little odd and awkward that a male asking you a question or, there is a query from a male on breast cancer. But nevertheless, I'm sure you will understand what my query is. And before I get to my question, let me compliment you for the beautiful, very precise, very crisp presentation on the disease, which is one of the most dreaded diseases. Thank you so very
Thank
much
you
for
so
that.
much.
Okay, now my question is, there was a young lady who just spoke to you about fibroadenoma, and you categorically told that, you look very young and at your age, you don't need to worry about fibroadenoma. So is fibroadenoma a cause of worry for an elderly lady? And if yes, then beyond what age is it a cause of worry? And if that be so, then what is the remedial action one should take after that age if she is detected or she is suspecting a fibroadenoma?
Sir, first of all, I'm very happy that a male is asking this question because this is exactly the taboo that we're trying to break. That, we need to stop thinking gender differences here and everyone needs to talk about breast cancer. Regarding your question, fibroadenoma. So, sir, as you said, if I know it is a fibroadenoma, then there is no worry. But when will I know that it is a fibroadenoma? Only if I have a tissue diagnosis. So if a lady who comes to me has a lump in the breast, gets a biopsy done, and on the biopsy, it clearly says that it is a fibroadenoma, then I don't think there is any worry. But if it is saying that fibroadenoma on an ultrasound or a mammography, then we still need to further evaluate it because a lot of times a lump may look like fibroadenoma on ultrasound or mammography, but it might be a cancer. So a biopsy proven fibroadenoma is not pre-malignant or it does not have any malignant potential. So it can be left. But there is another catch to it. The catch is fibroadenomas which are smaller or less than 2 centimeters, something we can still leave. But more bigger fibroadenomas or fibroadenomas which are showing some growth, then we are also thinking, are we missing out something which is known as phyllodes? So phyllodes tumor is something which looks like my fibroadenoma clinically on mammography, on ultrasound, and even on a core biopsy. Sometimes it is difficult to differentiate a fibroadenoma and a phyllodes. And then phyllodes has a potential to turn malignant. So that is the reason when doctors advise removal of fibroadenoma, it is because they want to be sure that we're not missing out phyllodes tumor. So, but if your pathologist is 100% confidently telling you, no, this is a fibroadenoma, there's no chance of it being a phyllodes, it's very clear cut, then you can actually leave.
Okay, I think one small question remains unanswered is that, beyond what age should one worry about fibroadenoma? If it is, or, that of course is a question mark, and a question of proper
Sir,
diagnosis.
a breast lump at any age
Okay.
has to be evaluated.
Okay.
At
Thank
any age. Sir, I have currently a 26-year-old lady with breast cancer that I'm treating.
Oh.
So I think now the age is not really a bar. It has to be evaluated. It has to be proven by a biopsy that it is benign, and then only we can stop.
Okay. So you would always suggest to go in for that biopsy. It's called FCNR or whatever it is. The medical, there is a term for it. There is a technical FCN.
No, sir.
FNC,
No. So
whatever.
FNC is fine needle aspiration cytology. We don't usually do FNC.
Okay.
We usually do a true cut biopsy, which is a core biopsy. FNC
Right.
is when a very thin needle is put in, and true cut biopsy is relatively thicker needle, which takes a chunk of the tissue. So FNC is not very foolproof. True cut biopsy is a better investigation. So.
Is true cut biopsy scary?
No.
Are you sure?
It's not scary.
It is painful, no?
I do all true cut biopsies in my OPD.
No,
So
no,
it
I
is
had to do it of the
painful,
thyroid. I had to
not
do it of
possible.
the thyroid. So I'm very,
Oh,
very
no, no.
scared.
So, see, breast and thyroid are two different
Yeah,
things.
that is why,
Yeah, so don't worry about it. Everything is done under local anesthesia. So, don't worry about it.
Thank you.
Thank you.
But men also do get breast cancer.
Yes.
Yeah,
Because
that's what she said,
my father-in-law
14%.
got it. Yeah, my
Yes, they
father
do.
had it.
No, no,
So
no. 14% was not the men's breast cancer.
no.
14% is if we see the incidence of breast cancer and if we see it across both the genders, then it is the most common cancer. But
Yes, yes.
the incidence of breast cancer in men is 1% of what
Well,
it is there in women. So it is
exactly. That's
low,
what
but
the doctor told
we have
us.
treated because I'm treating only breast cancer. So I have seen a lot of male breast cancers also.
But comparable to the rest of India, is West Bengal in high risk?
It is a place where people they don't come early. They keep waiting because they till the lump grows to a specific size. There's a lot of alternate therapy which goes on, homeopathy, Ayurveda, and then they come to us only when it has reached a specific size, and that is the reason the outcome is relatively worse compared to other places.
But nobody's really found out the reason being why they come so late. Because I find the south of India, they're very sharp. They go in much faster. I've seen that. So that's why I'm just saying, relatively the graph I've seen, it's
I
pretty
think
high in West Bengal.
this is more
Like it's
social.
very scared. Like today, I'm saying I'm so scared. I'm quite educated, everything, but still I'm scared. So I think
It's like human nature. Like I guess that's what it is.
And there's another thing which I've realized that the residents of Bengal, they don't trust doctors from Bengal. So
yes.
there is a tendency to go to Mumbai or South or Vellore, which is very, very strong, and I think that also delays the treatment in a way because then you really need to be uncomfortable to take that step and go
I
all the
totally
way.
agree with you. I wanted to go to Bombay, but since I couldn't go to Bombay, I'm opting for Calcutta. I'm being very
Yeah,
honest.
so I am trained at Tata Hospital, Mumbai, and what we are doing here is exactly what they are doing there. There's no difference, but it's just about how everyone looks at it.
But why is it that?
That is difficult to answer. I don't know.
Yeah, in fact, I can second the doctors the things. I came to know from that Mumbai doctors, Mumbai Cancer Hospital is not recommending to Calcutta Cancer, which is same Tata, but they are recommending NH.
Because Tata Mumbai is not the same as Tata Kolkata.
Yeah, that was
Tata Kolkata is not a branch of Tata Mumbai. Tata Mumbai is a government of India institution. It's a central government institution. Tata Kolkata is the Tata's.
Tata and undertaking. Yes.
It's just and that is Tata Memorial and this is Tata Medical. So it's just a similar name. And I think this recommending NHS because the whole team, we've all trained from Tata Mumbai, so they know us. And
So they recommend Apollo also a lot.
Yeah, Apollo also, I think they recommend. Apollo also, there are a couple of people, but I don't think there is anyone, I'm not sure. I don't think there are Tata pass outs at Apollo. I think.
Actually, I'm talking about 6 years back. I'm talking about 6 years back, not now.
Yeah, so our team has come here mostly, I think since 4 years, we have mostly started our work at NH. So before that, we were in Mumbai.
I have a question, Dr. Neha.
Yeah, Arvind, go ahead.
Yeah, just wanted to know something like genetic testing of cancer. What is that basically?
So genetic testing of cancer is not really, actually, we don't test the cancer. We test whether there is
Revival chances,
there is an
something
inherited
like that.
mutation in the body.
Okay.
So, we have a lot of genes in our body, and they are given certain tasks to do certain functions. Now, if there is a mutation in one of those genes, then that mutation increases your risk of having a cancer in your lifetime. For example, if someone has a BRCA1 or a BRCA2 mutation, then their lifetime chance of having a breast cancer is more than 60% and having an ovarian cancer is more than 40%. which is a very, very high risk. And these mutations, they can be passed in family. As in, there's almost a 50% chance that you can pass it to the next generation. But good thing is, we have ways to test, if we just collect your blood or tissue, we have ways to test whether you have inherited that mutation or not. So it is done by testing your genes for that specific mutation. And if you know that you have that mutation even before you develop cancer, then the good news is then you can take certain precautions. You already know that you have that mutation, the chance of having that cancer is very high. For example, there are people who get both their breasts removed if they have a BRCA1 or BRCA2 mutation. Or people who get very, very close active surveillance. They get very regular checkups to detect cancer. There are people who get their ovaries removed after they have completed family, if they have these kind of symptoms. So there are ways to decrease that risk and protect you from that.
So, Mane, is there any normal chances or any person, like any lady, can get it checked easily before that?
There is a very set indication of getting a genetic test done. Like the national NCCN guidelines are there that who should get a genetic testing done. If someone has had 2 or more first degree relatives with breast or ovarian cancer, and there are a whole set of guidelines of who should get it done. But regularly, a normal person who does not have a very high family history of breast cancer, they don't need to get it checked.
They should not.
No, because they'll end up just finding various unknown variants in the test and will not know the significance of that.
Okay. Thanks. Thank you.
So it's about to be 6 in the evening, and doctor has further meetings onwards in 15 minutes. So if any further question by anybody, then we can sum up. Please unmute themselves if anybody wants to speak anything. Shall I take house to be closed? Okay. Thank you, doctor. Now I request the president. Now I request the president of Avyana to unmute herself and give formal vote of thanks to the audience as well as the doctor.
Okay. Good evening, respected Rotarians and all our other non-Rotarian members who have joined in. Excellent program. Thank you so much, the whole team of Yuvis, especially Naveenji and of course Dilipji, for letting us partner in this event. And what a wonderful, wonderful session, Dr. Neha. You're really like a sister, you're a young girl, and you explained us so well. Wish you all the best. And this really is one of the cancer per se is becoming such a, I can't call it a pandemic, of course, but it has become a major cause of concern and death, and the spread is amazing. And I, as a senior person would say that maybe all the hospitals and also, young doctors like you should make an effort for more awareness. If we can partner in any such event, you can tell us, it could be just innovative ways of advertising, of having this kind of sessions and seminars where it is, you began saying that, some people think it's a germ, something it's an infection. And along with that, I'll say that especially breast cancer is such a social taboo for most of us women. Many of the women, it could be vanity, it could be, like you said so well, that to many of the women, it is identity. So without getting into any value judgment, but these kind of awareness is so much needed, because going forward, cancer is going to be a hell of an issue to tackle. So the more we know about it, the more the next generation is aware of it, that much better. So once again, wishing you all the best, and thank you everybody for letting us have this beautiful session. And like our club secretary Sheila was saying, that this is the good of being on the virtual platform, that everybody could be here. Somebody was sipping tea also, and I was missing my cup, that you were getting so engrossing. This has been with one of the most scary topic, a very pleasant evening. So the credit goes to you and to Yuvis. Good night, everybody, and thank you.
Thank you, madam. Thank you very much. Before we conclude, I'd like to say something on behalf
Yeah,
of
please.
Narayana Super Speciality Hospital.
Yeah, please.
We'd like to
Yeah.
thank Mr. Pawan Jain especially very much. Thank you, sir, Pawan sir, and Naveen ji. Because of you people, I would like to thank the Rotary Club of Yuvis, Avyana, for organizing such a wonderful webinar, such a wonderful platform for us. I would like to thank our speaker, Dr. Neha, madam. Thank you very much, madam, for taking time out of your busy schedule. I know you are running short of time to join one more webinar, which is our national webinar, which will follow after this from Narayana, Bangalore. And we'd like to just let you know that Dr. Neha, madam, is available for consultation at Narayana Super Specialty Hospital. And if anyone is interested to like show her or meet her up, so you can contact Pawan sir, Naveen ji, or myself. Will be guiding you up for this consultation. So, like finally, it's really very appreciated from you people all. And Naveen ji, now you can take it forward from here.
Thank you, Mr. Irfan. Thank you.
Thank you.
Thank you, sir.
So now I think no more question or anything to be in that, because I'm also like an Indian old cultures. We feel shy to speak on these issues. But whatever, it was a wonderful experience for me. Now I'm handing over and asking President to terminate the meeting if there will be nothing to discuss.
Yeah, thank you, Naveen. Just a formal vote of thanks has already been given by Madam Raslakshmi, and so nice of all of you to join us, and Narayana staffs and the Neha, Dr. Neha. It was a wonderful session. We learned a lot, and our people, our members, take a keen interest into this. This really, it's a very knowledgeable subject, and. With this, I will thanks my service director medical. Basically, Pawan Jain is our director medical. He is having the very much interest in the medical projects, and he took the interest in organizing this. And then the active participants of Naveen. With this thanks, I'm terminating the meeting with a hope of joining for such more projects in the future to come.
Thank you, everybody. Thank you, everybody. Thank you, Dr.
Good night.
See you. Good night. Good
Yeah.
night.
Thank you,
Bye-bye.
Rajat. I'm terminating now. Once we'll have an official adda sometime.
Sure. Looking forward.
Surely.
Looking
Yeah,
forward.
sure.
Thank you.
Thank you.
Thank you, sir.
Bye-bye.
Thank you.
Bye-bye.